My name is Dr. Claire Reidy. I am from the Nuffield Department of Primary Care Health Sciences at the University of Oxford. I'll be presenting a national evaluation using qualitative methods. This work has been undertaken with Dr. Prasanth Papuzzi from the Nuffield Department of Primary Care Health Sciences at the University of Oxford, who's leading on the qualitative work, and our core project team, which consists of principal investigators, Dr. Felix Greaves, who's at Imperial and NICE, and Professor John Powell at Oxford and NICE, and our lead PPI representative, Dr. Bernard Gudgeon, and the quantitative team are Dr. Kira Costello, Dr. Anthony Laverty, Mr. Kriti KC, who are at Imperial. We also have a number of wider research collaborators who are also listed here. So our research questions for this study are: how and why do patients and carers use or not use the NHS app, and what are their experience of technology-enabled access to primary care? Also, secondly, the experiences of healthcare staff with the NHS app and its integration in the service. And third, what background work and ongoing adaptations are needed to accommodate the impact of technology-enabled access to primary care? Our fourth question is around the role of local commissioning groups and national delivery teams. Enabled options for accessing primary care and other services. Our fifth question is: what are the perceived implications of the NHS app for access, efficiency, safety, and overall experience in primary care over time? Our sixth question is: what transferable learning can we draw from the example of the NHS app to inform the implementation, national rollout, and routine use of healthcare technologies? So the study is a formative study, which is, oh, sorry, I've gone forward one. The study is a formative study, which is designed to feed into the development and integration efforts of the NHS app, which is followed by a summative analysis. It has a comparative case study design with 4 GP practices as case study sites across England. And we have been speaking to patients, so users and non-users, carers and members of the public, NHS staff, commissioners, NHS delivery teams, and policymakers. We've used a number of data collection methods, including semi-structured interviews with all participants and think aloud interviews with some NHS app users, so more intense interviews, face-to-face, going through what they have been using on the app and experience the app. We've also undertaken focus groups with patients and carers and undertaken ethnographic observations in the practices. These are the 4 case study sites. We have one there in red, which is in the southeast region of England, one in green there in East Midlands, third one in the northwest, and the fourth one in the north. Our case study sites cover, we recruited them based on a number of different features, such as population sizes, locations, digital maturity, and population serve. So they serve different ethnic populations. For example, our case study site 4 there has a mixed ethnic population. It has a high South Asian and Black population from the West Indies. And our site here, which is purple, has a majority South Asian population, about 95% South Asian, with a large number of the population with English as a second or third language. Analysis was informed and sustainability framework, the NAS framework, which is an evidence-based framework to guide thinking on implementation, rollout, and embedding of technology-supported innovations in health and care. We have collected a number of types of qualitative data so far. So focus groups. So we've been 4 focus groups with people from different backgrounds and conditions. We had a focus group with people with type 1 and type 2 diabetes, with long COVID, with Parkinson's and HIV. We've undertaken observations in the different GP surgeries we've recruited, and interviews with 59 participants, consisting of 25 patients of different ethnicities and caring responsibilities, and living with a number of different conditions and in different locations across the country. 20 healthcare staff, ranging from practice managers, GPs, admin roles, and nurses, and also from a range of ethnicities as well, and 14 stakeholders working in commissioning, NHS delivery, and working. I want to present some of our preliminary findings now. Firstly, in relation to some patient experiences and in terms of what people have found helpful, for example, this quote in orange outlines how some people have found the NHS app to be easier than the traditional way of getting through to a surgery. The quote here in green on the right there shows how some found the NHS app to be quicker and easier than other apps. And the quote below in purple shows how some people found the NHS app as a useful and convenient way to access personal health records, such as providing dates of consultations, test results, prescriptions, and details of consultations. And the quote in red in the bottom right describes the value of proxy access. I'll just read this one out. So I've gone from having to carry a big bag to now just a small bag. You know, referrals and things are on there, letters and appointments, medication-wise and everything. I could just pull it up and say, this is what I want, or this is what my son is on, or my mum. It would have all the interactions on there as well. You don't always have to remember like what patients we have picked out a number of themes that are coming through the data as well. These are around the complexity of implementation at scale across the NHS infrastructure, developing for direct and indirect users in a constantly evolving context, translational tasks which become relational in practice, and the potential to augment existing and generate new inequalities. So first of all, complexity of implementation at scale. So we're finding that there is a lot of complexity in developing an app that is able to meet everyone's needs. For example, it's difficult to sustain value of the app for all parties. So if someone's using another app, why would they change it over to using the NHS app when another is already meeting their needs? So if we look over to the quote in green on the right, I'll just read that out. I don't use the doctors that much, maybe like once every 6 months or something, maybe at the most. I don't think it would be really worthwhile to download or register the app. So why would someone download the app if they only require it infrequently? Surgeries to integrate the app? And is it worth the effort for them to change over to using the NHS app from another one? And if we look over to the quote at the right, that outlines that a bit more. So to be honest, we've had no training, no guidance when it comes to how the NHS app works. We just have to sort of take it as it comes to find a solution. And when you do that, you know for the next time. So it's more work for them to have to undertake. And also there appears to be frustration from patients who are unable to undertake high value tasks, such as booking an appointment or accessing their full records. Also, the app is a portal and it relies on integration with NHS infrastructure, which means that there's variable access for patients as implementation depends on the GP surgeries, and the app is as good as the surgery is able to make it. And in terms of more findings around the complexity of implementing it at scale, there appears to have been a lot of emphasis on the development of the app and what it can do and look like, and less on the actual implementation of it. It seems like a handover of responsibility for that to patients and practices. So we look at this quote on the right, which is referring to when there is an issue with the app. And app users are told to refer to their GP surgery for help with the issue without any context. So this practice manager is saying, and then of course it doesn't verify them. It doesn't tell them that's why. Whereas if it did a very quick form back to us or something, I feel that process could be made a lot easier. It just says, contact your GP practice. So that's our main frustration with the app, to be honest. And then the quote below in orange. So we've never kind of commit to backing that app. In fact, the opposite. We kind of said, right, you know, people could choose whatever they wanted, and therefore I think it led to confusion. So by not encouraging people to choose the NHS app over other apps, it's led to confusion. So this next point then around the awareness of the app. So the NHS app is designed to have add-on services such as video consulting, patient knows best, e-consult, things like that. But then being able to access these additional services. And patients express frustration over the lack of promotion of the app and confusion over what features it offers. So you may be able to go into the app and decide you want to look at other things. So a cross-selling kind of element that might work sometimes, but it doesn't always work when patients don't know to look for more things. This quote here in the orange: we've never kind of commit to backing the app. In fact, the opposite. We kind of said, right, people could choose whatever they wanted. And therefore, I think it led to confusion. So developing for direct and indirect users in a constantly evolving context. So how to do user research on a continuously evolving product that reflects a continuously evolving and fragmented service. So we look at this quote in orange. I think this describes it a bit more. From a stakeholder in the development team: users don't have a mental model about what it should look like and what it should be. So we found our research what things should be or what it should look like. And so research has been quite difficult, because the language doesn't exist about these things. We don't have a common language to describe your COVID pass. Also, there seems to have been a focus largely on direct users, the patients, and less on those who are indirect or implicated users, such as practices and CCGs. Yet the implementation of the app affects them too and relies on them. So if we look at this quote in green from a commissioner on the bottom right, some GP practices were still quite resistant, but because it was that requirement that you must have an online consultation in place to do total triage, and PKB, which is patients know best, was our online consultation solution, it meant that we had to do a bit of quick and dirty deployment, whereas what we wanted to do was get it working really well and then expand on that. So our practices users, as those at the front line of the app, are, they had beacon sites at the beginning. And is the patient using the app an app user, or are they a patient in a publicly funded system? So what is the app designed for? Is it designed for detailed, sensitive health interactions or fast use? Which impacts on how patients are viewed and retained and the buy-in for the app. There's also been comparisons to banking and casino apps, which may not translate in healthcare. Is the NHS app comparable to these other kinds of apps? Because there's more sensitive data, mental health records, and things like that. Further, the uniqueness of an all-in-one primary care app means that people don't always know what to expect or to deem useful. So this theme is around translational tasks which become relational in practice. So for example, it may sound simple to have an app, as the app is an appointment booking system, although surgery staff have described, patients misbooking appointments. So they're not to them to, e.g. a physio or a pharmacist or a nurse instead of a GP, or they're block booking appointments, all of the appointments they could. So this blue quote here, the GP partner said this: the NHS app right now is a way of getting to the GP surgery, which is good, but I guess patients have to understand and value NHS more. And that can only happen if the NHS app shows them how to use this. We had a system where patients could book online appointments and they would just go on and block every appointment that was available on the system. So the NHS app perhaps can lead on to a lot of misuse. Also, there is a complexity introduced with the NHS app, such as with symptom checking. Which was useful for some for self-management, and patients, however, may turn to Google still to book appointments. Google to look up their condition or what they're seeing on the symptom checker, or make an appointment, but then not be able to book an appointment, creating more frustration. Also, registering has been difficult for some. It can require formal ID, up-to-date phone, and further liaison with the practice. Also, there are potential safeguarding issues, and records are traditionally institutional. They're not traditionally patient-facing, so they may require some care and translation. So this quote here in the purple describes that a bit more. So, of course, when all of this information was recorded originally, nobody knew how it would be presented, 10 years down the line. So I think that is a challenge as well. And, there are patient perspectives that it should be more about a choice for the individual rather than whether the practice will provide access. Also, the app may have potential to augment existing inequalities and generate new inequalities. So we're finding important cultural considerations while we're speaking to different patients and the different practices. So one of them is a language barrier and the need for the app to be available in more languages. Also, whether all of the features on the NHS app are relevant to all, such as symptom checking. One patient described her experience to me, which is in the purple quote below here. I had these big black marks that came up on my face, all big and lumpy and purple, and they ask you questions. And then they ask you what colour they look like and the colours that they've got. And I can't see that on my skin. It's just little things like that make you feel like you're other and you're not involved, and they're not really taking your care and consideration into account. Some other things that are coming up are around the importance of building trust for some patients. So while the NHS app is valued for some elements, such as prescriptions and test results and health records, virtual consultations and triaging seem to be a bit more limited, where face-to-face interactions and engagement are required to build trust with ethnic minority populations. So we look at this quote here in the top right in green. This feels like, why should I have to do more digitally to speak to someone about my health? Hearing the individual and seeing them nod and agree and having that conversation with you where you feel I've been heard now. So this patient was a South Asian older lady, and she felt that while she could use prescriptions and things, online prescriptions, actually to have a consultation, it was more beneficial to be able to see the person face to face. Also, there were concerns around the intentions and engagement. So intentions around encouraging the app use. So they're following encouragement to use the app for the COVID pass and vaccinations. There was some kind of concerns about, why do you, the government, care about me now when there didn't seem to be care about my health beforehand? So why are you pushing me to use an app now when you were never trying to look after my health before? Viruses and also security and trust. So being clear about what's happening to personal data and the NHS being privatised, for example, external companies being added on to the NHS app. And there are more points coming up from the intervention generated inequalities. So there were discussions around the NHS app creating disparities where someone who doesn't have the means to book appointments online or access prescriptions and things like that might be beating and playing the systems over people who aren't able to use the app. And also around unlocking, and so the potential to unlock or enable social network support. For example, some practices have highly connected community groups or key individuals who support uptake of the app or other digital tools. We read the quote here in red in the top right. We go along to the stand in the surgery and talk to people and tell them about the app. We would both be quite happy to go. That's her and her husband. To sit in the town hall and advocate for it, because yeah, it's ridiculous that you've got something like that on your doorstep and it's not been taken up. It's ridiculous. Also, some patients follow up on referrals and things like that, promoting self-management and patient empowerment. This quote here in the green describes that a bit more. So it sounds trivial, but being able to manage your own health from an app like this can help and can have really big consequences for your life and your life chances and your opportunities. And that's what I want to do with it, and get people to be self-helping, because you just can't wait for things to happen. You've got to be proactive. There were also discussions around the app enabling people, older people, or those with disabilities, if they're unable to attend the GP surgery, by accessing the GP surgery in a different way. And so that's our findings so far. We've got some next steps. We have further meetings with our PPI team to discuss and develop these findings. We're also disseminating at academic conferences such as this, and further interviews with stakeholders, further in-depth analysis and narrative case studies, dissemination of the results alongside our PPI group and journal articles, and also a final report. So I'm sure we'll reveal more shortly. Thank you for listening.